I think, and we probably won't go through all the detail here, clinical pathways are a great way to engage clinicians in both evidence-based care and in ongoing continuous learning. So let's look at the next slide. So what is an honest clinical pathway? It tells us what we do and don't know. Most pathways, let's say for the treatment of diabetes, diabetic ketoacidosis in the hospital, or for cardiac surgery, or for hip and knee arthroplasty, they contain a number of components that are evidence-based and we're really quite sure about, but numerous parts that we are basing on opinion or consensus where the evidence is really incomplete. And we want to understand where we know so much, we're so sure that we want strong adherence to those elements of the pathway, but to call out where we're not so sure, we want clinicians to use their judgment and, if they think prudent, deviate from the pathway. This allows us to learn from those experienced clinicians who have seen anomalies, something that disturbs them about the clinical pathway we put out there that they think we ought to change and maybe learn from. Next slide. This is something I want you to study on your own, if you would, please. This is Richard Boehmer, one of the most brilliant folks in organizational change. And he simply points out that we have a range of knowledge about almost everything in healthcare, ranging from complete ignorance, which is stage one, and this would be diabetes, where people had sweet urine, people used to taste the urine, and then people wasted away and died, and that's all we knew nothing about it, to complete knowledge, down there, number 8, where we know all the factors that interact to affect a patient with diabetes, make them sick or make them well. And we can actually have artificial pancreas or transplantation or ways to totally make this something we can capture, understand, and act upon. So simple, in fact, that diabetes care in general can be left to the patient because the rules, the evidence is so clear that doctors really don't have to get involved 99% of the time in the care of diabetes these days. Next slide. So what's in a clinical pathway? First of all, it specifies a relatively homogeneous population. This is a helpful, but it's also a bit of a curse because very few patients whom I know are homogeneous. They have multiple diseases, morbidities, and so forth. And saying that finding patients that are all alike means you've taken only a minority of the patients you need to care for. But clinical pathways have to have a relatively homogeneous population, let's say with simple diabetes or simple hip replacement. Then you do an evidence review, and where evidence is solid, you determine that by doing formal evidence grading, and the Cochrane collaboration, which many of you have heard of, that's what they do for a living, and so you can usually find where the evidence is strong. There are clear boundaries in place and time. Where is this pathway starting? So in hip replacement, it ought to start where the patient comes to the doctor saying, I have pain in my hip, and a decision is going to be made whether or not to do surgery. And it ends far enough after the surgery so that the patient-reported outcomes, their functional status, their pain level, what they can do, can be actually assessed outside of the immediate operative period. There's a process map that shows this entire pathway. Those of you who aren't familiar with process flow diagrams, you just Google it and you'll see simple ones will come right up for you. But what I like to see is not just one pathway. I like to see a pathway with swim lanes, like in an Olympic pool. Each swimmer has their own lane. The physiotherapist, the nurse, the social worker, the surgeon, the consultant, they all have their own swim lane, and where they interact with the patient is specified on that process flow map. And of course, you need a measurement framework to determine whether those key steps in the pathway are being followed or not, and whether the outcomes you want to achieve are actually being achieved. So next. There are a lot of challenges to doing pathways. It's a lot of work to create them. They only cover a fraction of all the things you need to work on in a healthcare system. It's very time consuming to analyze them and revise them. Most electronic medical records aren't designed to support this. They were designed for purposes of charging and billing and capturing data about efficiency. And if there are ambiguities in the evidence, hopefully you can get some learning from clinicians who practice in different ways and you study what they did, but it's really pretty hard to resolve ambiguities in evidence without a more formal way of doing it. Next, please. When you're doing a pathway, clearly indicate to whom it does and doesn't apply, and be careful about frail elders with 12 morbidities and 22 medications. Incorporate checklists. Checklists are really powerful. I'm sure many of you have read the Checklist Manifesto from Atul Gawande, and you know that Peter Pronovost used a checklist in his Keystone project. They're really helpful, but they operate at specific points in that overall clinical pathway and system, and building them in. So you say, this is where you need to use the checklist is really helpful in driving what you do and in collecting the data. The checklist itself is a data collection tool. Build in checkpoints. So in giving antibiotics and the antibiotic stewardship movement now, there's an antibiotic timeout. You start your antibiotics, 72 or 48 hours have gone by, the cultures are available, take a timeout. This is the time to say, we should be stopping them here unless we have evidence to continue. So those kind of checkpoints are really important. And really important are standardized order sets. When we order tests, pharmaceuticals in clinical care, having a standardized order set that makes the best practice the default and forces the prescriber to say, well, I'm not going to do it that way, and here's why, can be a very, very powerful learning tool and also drive better behavior. It's part of behavioral science, actually, and systems engineering to kind of nudge people to do what you think is evidence-based, but allow them always to opt out. Next. And this is the important point. Do allow them to opt out, but require physicians to document why they're deviating the pathways so you can have, in fact, a learning healthcare system. And I've never seen, and I've done some expert witnessing in medical malpractice, I've never seen a physician successfully sued if he or she recorded in the medical record why they deviated from so-called standard care. Be skeptical if a given physician is constantly deviating from something that's explicit rules-based, evidence-based care, but be extremely permissive and learn when we really don't know the best practice and we want to take advantage of the clinician's tacit knowledge. And just be realistic about what it takes to maintain these. I think that may be coming to the end. Can we just check to see what the next slide is? Yes. There's an example that follows this in the slide set you're going to have access to of how to embed quality measurement in the clinical pathways and into routine work so that you can immediately see how you're doing. So the data is visible and is fed back right away to the care team. If somebody says to you, well, we can't collect that data as part of routine care given the way we provide care, challenge them and say, well, maybe your system needs to be redesigned so that you can actually capture the data you need to provide optimal care while you're giving the care. If they say we need to hire a nurse, forget it. Nurses are really valuable commodities. They shouldn't be commodity, bad word. Sorry, all the nurses out there, you are not commodities. You're very talented individuals who are absolutely critical to care. Sorry about that. But you're valuable, and we don't want you sitting around with a notepad keeping track of measures on clinical care that should be part of the routine care. Always think about balancing measures, right? You may have the best idea in the world, and for example, you want 100% adherence or compliance to isolation precautions for patients who have MRSA or methicillin-resistant staph. You've had a huge problem in the past in the NHS with that. You want people to be put on precautions. That's great, except when you do that, be aware that they're going to be stigmatized. At least they may feel that way. We know that caregivers don't go in the room as often because they have to gown and glove and do all that kind of stuff. And that can be really counter to doing the best possible care. And by the way, gowns, gloves cost money, and it takes, I've seen data, 17 to 27 seconds to put on that stuff, which is a large amount of time if you've got 20 patients on precautions in an ITU.